So first, thank you for the organizer team and the scientific committees, and thank you for inviting me today. It's a great pleasure and honor for me to be here, especially with my mentors. I'll talk to you today about myasthenia gravis and the updates on the management of myasthenia. So we know that myasthenia is the commonest primary disorder of the neuromuscular junction, and we have more than 700,000 people affected by this disease worldwide. And the incidence is increasing in the past 50 years. So at least 15% of those patients are refractory to treatment and remain with disabling symptoms. And several other patients can't tolerate the existing immunosuppressant treatment. So the existing standard of care for myasthenia depends on using broad spectrum immunotherapies that work on different mechanisms of action, but it's a general or broad spectrum medications. Disadvantages of such medication, first, we have mixed efficacy from clinical trials. So it's not the efficacy that we aim for. And because they're broad spectrum immunosuppressant agent and the long-term use, the patient is susceptible for life-threatening infection, wide range of systemic side effects, and there's an issue with delayed onset of action up to several months, and for maximum efficacy, sometimes it takes more than a year and a half to have maximum efficacy of such medication, in addition to long-term risk of malignancy and drug toxicity. However, because myasthenia has a very specific immunopathology, why don't we use a more selective novel immunosuppressant agent that targets this selective immunopathology and an aim to have focused treatment that is more effective and with a sustained remission, less use of steroid because of a better steroid sparing action, relatively faster onset of action, and because they're more selective and directed medication will have less side effects. So in this talk, I'll be going through these novel immunosuppressant medication, and I'll talk about a few of them in details. So in order to understand how those medications work, I'll just briefly go through the pathophysiology of myasthenia. So it's a prototype of humoral immunity. So the B cells play a central role in this disease. However, it is driven and triggered by T cells after encounter with antigen-presenting cells. It stimulates B cell, and so B cells are activated, they proliferate and differentiate into short-lived plasma blasts, and then we have the long-lived plasma cells that secretes very specific antibodies directed toward acetylcholine receptor complex at the postsynaptic membrane. And then here at the postsynaptic membrane, encounter with these antibodies lead to destruction and simplification of the folds, either through complements or endocytosis and internalization in cases of acetylcholine receptor antibodies, and also for LRP4. But in MuSK patients, the complement does not play a role in destruction, and destruction of the postsynaptic membrane is through inhibition of clustering of AChR. So if we want to target specifically different players in this pathophysiology, we want to have a better directed treatment. So the first one is B cell depleting agent. So we will be working on this part of the pathway. So rituximab is a anti-CD20 monoclonal antibody, and because mature B cells express CD20 on the surface, then rituximab will target these B cells, autoreactive B cells, and lead to their destruction. However, it's very important to notice that plasma cells and plasmablasts lack CD20, so they will not be targeted by rituximab, and we'll see later why this is important. Most data we have for use of rituximab in myasthenia comes from single center experiences and case series, so it's still off-label. This is a systemic review for investigating efficacy of rituximab in 169 patients with generalized refractory myasthenia, including patient with AChR antibodies or MuSK antibodies. And you can see here that the clinical myasthenia scores improved significantly with use of rituximab, and there is decrease in the rate of relapses post-treatment. However, the observation is significantly more remarkable in patients with MuSK antibodies, with remarkable improvement, clinical improvement, and decrease in rate of relapses post-treatment. And also you can notice, because MuSK antibodies, unlike AChR antibodies, they correlate with disease severity, and they respond to treatment. So we can use them for follow-up. You can see there's a significant improvement or reduction in the titers after rituximab treatment. So in addition to this systemic review, more recently, we have other retrospective studies from different areas, from Australia, Stockholm, and all confirming the same observation of clinical improvement and decrease in rate of relapse, especially for patients with MuSK antibodies. BEAT myasthenia is a phase 2 double-blind placebo-controlled randomized controlled trial that investigated use of rituximab as add-on treatment, but only for patients with AChR positive antibodies. So MuSK patients were excluded, and this trial didn't reach its main endpoint, but it showed that the medication is safe and well tolerated. So why it was negative? First, we still don't have the full results to properly interpret this trial, but we can notice that baseline scores were relatively low. So maybe the patient had a mild disease, too mild disease to draw conclusions. Also, there's potential theoretical development of anti-chimeric antibodies toward rituximab, and most importantly, because MuSK patients were excluded, and those are the ones that had significant improvement with rituximab. Another possible reason is that, as mentioned before, rituximab does not target plasma cells and plasmablasts. And so not targeting these medication, it's either that we need a longer or repeated cycles, not just 2 cycles of rituximab, because these are long-lived cells. And so this is one possibility. Another possibility is that we need a special medication that targets those plasma cells because they continue secreting antibodies. And the third possibility is that we are giving rituximab too late in the disease, in which the main secretors of the specific antibodies is the long-lived plasma cells, not the B cells. So maybe we need to consider giving rituximab in future trials earlier for better response. So to conclude, where does rituximab stand in the management of myasthenia? It is considered for treatment of very severe refractory patients, but we have a lower threshold for patients with MuSK-positive antibodies. It is safe on the long term. And regarding risk of PML, there are 2 case reports of patients with myasthenia who develop PML on rituximab. However, because it's used after for refractory patients who have been already on other immunosuppressant treatment, it might be a confounding factor. Data from rheumatological diseases show that risk of PML with rituximab use is less than 1 per 30,000. So from now we'll go for another treatment modality. So we've discussed B cell depleting agents. We'll go way to the end and discuss complement inhibitors. So as I mentioned earlier, complement play an important role in destruction for patients with AChR positive antibodies, but not for myasthenia, for MuSK, sorry. They do that after binding of the antibody to the receptor. Complements activate the classical and common complement pathway leading to destruction. So, and the rationale for use of these medications is because a patient with low complement titer because of consumption, it correlates with clinical severity and higher levels of AChR antibodies. And also for animal studies, with complement knockout mice, they have significantly lower incidence and severity of experimental autoimmune myasthenia gravis. So what about human trials? We have one complement inhibitor, which is ocrelizumab, that from the REGAIN trial, which is a large phase 3 trial, double-blinded, placebo-controlled RCT, enrolling 125 patients with refractory generalized myasthenia, but only AChR antibody positive because of the complement. And it was investigating use of eculizumab as add-on medication. And the primary endpoint, which is change in the clinical scores of myasthenia, were not met. However, because multiple secondary endpoints were showed significant improvement, it led to approval of this medication by the European, American, Canadian, and Japanese, and it's under investigation in the UK. Issues with use of eculizumab, in addition to cost, is that it's limited to AChR positive patients, and because it was investigated as add-on medication, we need concomitant immunosuppressant therapy. However, maybe it's a good option for severe myasthenic crisis. I have to mention that there is risk of meningococcal meningitis and Neisseria meningitis vaccination need to be given 2 weeks, at least 2 weeks before starting the treatment, and then repeated after 2 to 5 years. So we'll switch again. So we talked about B-cell depleting agents, complement inhibitors, and then we'll go to the antibodies. So we want to discuss the role of antibody blockers. So FC receptor inhibitors, we know that neonatal FC receptors are very important for the maintenance of immunoglobulin hemostasis and protect them from degradation, so prolonging their half-life. So if we inhibit those receptors, this will lead to rapid fall in the IgG and thereby the immunoglobulin, the antibodies in myasthenia. So for clinical evidence for risanoloximab, which is a high affinity anti-FcR monoclonal antibody in phase 2 trial of patients with either AChR or MuSK antibody positive generalized myasthenia, it showed promising results. Phase 3 is still ongoing. The same for efgartigimod. However, it was tested only in AChR positive patients, and MuSK patients were excluded. So we discussed B-cell depleting agents, targeting antibodies and complements, but what about the plasma cells and plasmoblasts that we mentioned, that are the main secretors of these antibodies? So these long-lived memory plasma cells, they lose because they lose their surface markers. They're resistant to most agents, and they may be responsible for treatment resistant. And because they're rapidly producing these antibodies, they need proteasomes to prevent accumulation of misfolded protein. If you inhibit those proteasomes, then you will lead to their destruction. Animal studies are promising. However, human trials are limited by toxicity because 30 to 40% of the patients have disabling sensory neuropathy. And I mentioned that T cells are the main drivers because they activate B cells. So why don't we target B cells and switch off the whole downstream cascade? And or cytokines. So this is also an attractive option. However, none is being studied in clinical trials yet. I'll go through hemopiotic stem cell transplantation. So we've been seeing a lot of publication of use of stem cell transplantation in different neurological diseases, including myasthenia. So in the conditioning phase, the immunosuppressing chemotherapeutic agents are given to ablate all existing autoreactive B and T cells. And then we have the stem cell phase to recover from post-conditioning aplasia. We have a retrospective trial of limited number of patients that showed promising results. However, because it's retrospective, we're not sure about selection of patients, and maybe the effect is due to the induction phase. and it's not necessary to go through the stem cell transplantation. So maybe only high dose cyclophosphamide induction will sustain the remission in severe refractory cases. And this is the final medication I'll discuss. So sub-Q immunoglobulin, we know that IVIG have strong evidence for treatment of acute myasthenic crisis. However, evidence is limited for repeated infusion on the long term because of side effects and because the effect, because it's fluctuates, the effect wanes before the second infusion. So, and because subcutaneous immunoglobulins have a sustained release, then they will have less side effect, and at the same time they will have sustained clinical efficacy. So they're shown to be effective and well tolerated. However, we don't know about their role in refractory myasthenia or how good they are as a steroid sparing agents. So I have a couple of slides about update on the existing standard of care. So we know that we are using mycophenolate as a steroid sparing agent, and we have several publications with evidence that discontinuation or marked reduction in the dose of mycophenolate increases the risk of relapses in myasthenia. So, and at least 30% of patients undergoing taper that is quick or there's a dramatic reduction, they will go into relapse. So yes, we can taper off mycophenolate, but after several years of disease stability, and it is advised of very slow dose reduction of not more than 500 milligram per day every year, or even half of that. IVIG, there's repeated evidence of their effect as acute medication. However, there's an interesting study, a double-blind RCT, they were questioning the use of IVIG in preventing myasthenic crisis in patients, stable myasthenic patients undergoing surgery with under GA, that showed that there's no need for preoperative IVIG in well-controlled patients to prevent myasthenic crisis prior to surgery and GA. So that's good evidence, because I'm sure that you noticed we have consultation asking about this question. And finally, COVID and myasthenia. Because patients are on immunosuppressant medication and it's autoimmune disease, are they more vulnerable for myasthenia? We don't have, COVID, we don't have evidence that myasthenic patients stable on immunosuppressant medication are more susceptible to COVID. So if the patient is clinically stable, is not lymphopenic, there's no data-driven reasons to change the immunosuppressant medication. If the patient is already on monthly IVIG, on maintenance IVIG, there's a theoretical advantage of natural autoantibodies, and it's better to switch them to sub-Q, self-administered sub-Q IV, immunoglobulin to avoid the exposure to hospitals. And if a patient on rituximab, because the B-cell suppression and clinical efficacy persist more than 6 months, it's better to prolong the infusion to more than 6 months. So in conclusion, with the existing broad spectrum immunotherapies, many myasthenia patients remain refractory to this treatment or intolerant. So we need management. Use of more directed, selective, novel immunosuppressant therapy are suggested as an aim to improve efficacy and reduce toxicity. And the recent trials with rituximab and biologic targeting complement and FcR and receptors are major steps toward targeted, selective immunotherapy in the management of myasthenia. Thank you.
Thank you, Dr. Abir.